So let's look at the anatomy of a report in pain medicine. So we start off with a summary of the case, usually provided by the legal team. I do a detailed pre-index events medical records summary, and then the same for the post-index events. If there are any employment records, we look through those, any information about sick leave, DWP records, again, if they're available, and physiotherapy records. And essentially, these are all put in chronological order. If there are any claimants' expert witness reports, then I will summarize that. Any defendants' expert witness reports, I'll summarize that. And obviously, if there are any joint reports, we'll look through that and summarize it. We then move on to the witness statements for the claimant and for others. The next thing we have is a section on the history of the patient's pain. Now, approximately 2 to 3 weeks before I see a claimant, we will send them out a detailed pain questionnaire, and that will ask them questions about their pain. So things like site, character, duration, radiation, aggravating, relieving, associated factors. So all the sort of description of their pain as they find it. We'll ask them about their function in terms of employment, what they can and can't do, their care requirements, interactions with family relationships, etc., etc. So we try and get as comprehensive a view of their pain as we can. We also send out pain questionnaires. These are standardized, validated pain questionnaires. So ones you might have heard of are things like numerical rating scales and verbal rating scales, which give some sort of score for the patient's pain. I do an examination, which we're going to talk about in a minute, and then give a conclusion about the claimant's pain. So examination, I mean, one of the most important reasons for seeing patients face to face is the hands-on examination. And essentially, the examination starts the moment the patient opens the door, or I open the door to them and they walk in. We're looking at illness behavior. Have they got a wheelchair? Have they got crutches? What's their affect? How are they behaving? Who have they brought with them? Have they got a chaperone or a friend, or any other sort of general information that can be gleaned essentially when they come through the door and sit down and present themselves to you. I'll then do a targeted examination, and the patients will usually in advance on their pain questionnaires make it clear where the areas of pain are. And then I will do a targeted examination of that area. So, for example, if it's neck pain, it would require a cervical spine detailed examination of the neck, the paravertebral structures, but also an upper limb neurological examination. So things like tone, power, reflexes, and light touch, pinprick sensation for completeness. And obviously, every area of pain and every area of the body has a very specific targeted examination that we do. And this includes inspection, looking at the area, and palpation, which is prodding, pressing, examining the area and trying to elicit pain. The other thing I do when I'm face to face with the patients is I do have other questions. Now I have a list of about 34 questions that I ask, and these are all the domains that we've really spoken about earlier. But it just gives me an opportunity to get further information, if necessary, from the claimant. So the conclusion, once we've got all of this information and we've summarized it, we've put it all together, then we need to analyze it. So this is in the conclusion section of the report. So we start off with simple things. The pre-index event summary. I will divide this into three, into the pain-related entries, psychological and psychiatric entries, and other health issues. So we get an idea of how the claimant was before the index events. We want to know, did they have an actual pain disorder, or was it just episodic pain they had, intermittent lower back pain, or did they have ongoing neuropathic pain or ongoing fibromyalgia or chronic widespread pain before the index events? Did they have any psychological or psychiatric disorders? Now, the two commonest we see, I would say by far in any of these types of reports, is a pre-events history of depression and anxiety. And we'll talk about that later, but that's very important when we look at how patients present with their pain and the effect of depression and anxiety on that. Did they have any vulnerability before the pre-index accident or pre-index events, physical, psychological, psychiatric? We then look at the index events summary. So what we're looking at is the instruction from your good cells will give us an overview of exactly what's happened. So that's a good starting summary. I then look at the contemporaneous records. So that's usually A&E records, hospital records, GP records, etc., etc. And then we look at the claimant's description and the events details. And it's really a case of cross-referencing all of those. Does it all make sense? And the important thing at the end of that exercise is the plausibility of the index events causing the symptoms that are reported by the claimant. The next thing we're interested in is an evolution of the pain and any other symptoms that the claimant complains of. So this is in the immediate aftermath of events, in the following days, in the following weeks, in the following months. And as was pointed out to me recently, it is possible to work out how patients' or claimants' pain has altered following legal advice, which was very interesting. We want to know, has the claimant had appropriate treatment? Have they been compliant with the treatment they've been offered? Were there any delays in seeking treatment? Has there actually been a resolution of their symptoms? Has the claimant been discharged from medical care? So that may be from the physio, from a hospital department, from a pain clinic, etc. DNA did not attend. This is very important, particularly as these claims roll on, patients not turning up for their appointments. Why not? And is there any evidence of secondary gain? So then we have to work out what type of pain the patient has. Now, at the beginning, we said there are these two types of pain. We have nociceptive pain. So this will be back pain, neck pain, arthritic pain, sort of general pain that somebody would have from an arthritic condition or a musculoskeletal condition. And then we said that there's this other beast, the neuropathic pain, where there's damage or dysfunction to an element of the nervous system, where the patients have much more florid descriptions of their pain. They might have much higher pain scores. It's also possible to have a mixture, of nociceptive and neuropathic pain. And there are various ICD classifications. ICD is the International Classification of Disease. It's currently in its 11th form. It's published by the WHO, the World Health Organization, and it is quite a useful document or website. If you go and have a look at it and you look at pain, it'll show you all the main categories of pain and then the subcategories and the sub-subcategories. So it is possible to give reasonably useful diagnoses using the ICD 11 classification. We then put in the reports a range of opinion. So in medical speak, we call that a differential diagnosis. But when we're dealing with medical legal cases, we just call it a range of opinion. And there's really three major categories. Number one, is there a biological or organic differential diagnosis? So this would be, does the person have CRPS, complex regional pain syndrome. If you think they do, then the biological organic differential diagnosis would be neuropathic pain, or it may be mixed nociceptive and neuropathic pain. Psychological, psychiatric differential diagnosis, it may be SSD, somatic symptom disorder, which we're going to talk about, mood disorder, adjustment disorder, or other issue. And at the bottom, we've got the so-called non-biological and non-psychological issues. So essentially here, we're looking at the spectrum of exaggeration, which we've discussed earlier. So just to put a bit together about SSD, somatic symptom disorder. Obviously, I'm a pain specialist rather than a psychiatrist, and this is the domain of psychiatry. But there is quite a significant overlap, particularly where you have claimants who have, shall we say, quite colourful pre-index events histories, and you know where they are when you do a summary, and you're confronted by 50, 100, 150 entries in the medical records before you've even got to the index event. So somatization is psychological or emotional distress, which is manifest in physical symptoms that are otherwise what we call medically unexplained. It's very common, 5 to 7% of the population, propensity of females to males. There's a heightened awareness of certain bodily sensations and a tendency to interpret as this being indicative of medical illness. The patients have excessive thoughts, feelings, and behaviors associated with those symptoms. And risk factors include childhood neglect, sexual abuse, chaotic lifestyle, alcohol, substance abuse, and personality disorders. For the actual diagnosis of SSD, really you need a psychologist or preferably a psychiatrist. But as pain clinicians, we do have to be aware that there is quite an overlap between pain disorders and SSD. The biopsychosocial model of pain, really, when we look at how a patient presents with pain, we're not just looking at, they've got shoulder pain and, it's the site is the shoulder. This is what it feels like. Their pain score's 6 out of 10. When they move their arm in this way, it hurts, etc., etc. Those are all the characteristics of the pain that we've described earlier. And that's the biological aspect of it. But there's also a psychological and a social aspect to it. So psychologically, as we said, patients are more likely to have mood disorder, particularly anxiety and depression. They may catastrophize. They may be under a lot of stress. And then socially, it will affect them. It'll affect their relationships, their employment, their care needs, their interactions with their friends, if they do or don't do their hobbies, whether or not they're in the medico-legal process, etc., etc. So when you then look at patients' presentation with pain, you go beyond just, they've got shoulder pain. You then look at their presentation using this biopsychosocial model. And this is standard in pain medicine. After the events and in the conclusion, I'll do a detailed analysis of the biopsychosocial model of pain. So we'll look at the post-index events, biological factors, which are the pain, post-index events, psychological factors, and post-index events, social factors, as we discussed. When we move on to the question of causation, generally speaking, there will be, and this is a generality, generally speaking, there will be what I would class a primary expert in these types of pain cases. Now, usually that's going to be an orthopedic surgeon. It may be a neurosurgeon in a spine case. It might be an obstetrician in an obstetric case. But essentially, they are the experts in the in the field that's the primary issue that the claimant has had a problem with. And in terms of causation, they are the experts that we go to for their view on causation. If there's any significant psychological or psychiatric issue, which is very, very common, pretty much ubiquitous in these cases, then I would defer to an expert witness in psychiatry. And if there's any other neurological or other issues, then we defer to the expert witness in neurology. Now, this isn't to say that for causation, as a pain expert, we or I would say, well, we don't know, we're pain experts, we haven't got a clue. We do, we have a very big clue. But for the purposes of the court and for the purposes of the medical legal process, we would defer particularly to the primary experts on matters of causation. Often we can give information as to why, for example, a claimant continues to have pain, for example, long after the healing of a fracture or long after the birth of a child, etc. We can give a lot more information about that. Again, when we're looking at causation, we also want to look at the natural history of the injury. So this patient's had hernia surgery and they got pain in their groin and it's ongoing. What's the natural history of that? Should it actually, in fact, get better within a few weeks or a few months? And if not, why has that not happened? Is it time limited? And often that can be helpful to have the primary expert witness to tell us that, you know, you would expect in XYZ circumstances, a tissue will heal, for example, and the patient shouldn't have any further pain or dysfunction. And then we come in and explain why that may not be the case. Causation, we're looking at essentially from one end of the spectrum to the other is there direct causation with the index events for the claimant's pain? Has there been a permanent exacerbation? Has there been a temporary exacerbation? Or at the other extreme, is there no causation, no direct causation between the index events and the presentation of pain that the claimant has? We then look at prognosis. Now, this is fairly standard, and the reason is, I will say, approximately X years and Y months have lapsed since the index accident. On the balance of probabilities, the claimant's pain is unlikely to spontaneously resolve. On the balance of probabilities, the claimant's pain will continue indefinitely and can therefore be considered permanent. Now, the reason I can make that generalization is, as we said at the beginning, chronic pain is defined as pain from 3 months or more. And as you can imagine, by the time I see a medico-legal claimant, the minimum is going to be 2 to 3 years, up to 5-ish years. They've had that pain for some time. So they have got a chronic pain problem by the time they come to see a pain expert. So we're just going to do a little overview of treatments and the treatments that can be offered and suggested in the medico-legal reports. First and foremost, in pain medicine, we use a multidisciplinary team approach. So pharmacological agents, this is usually the domain of pain doctors. We use lots and lots of medications, anti-nerve pain medications, some of the ones that you will have heard of here: pregabalin, gabapentin, duloxetine. We have a bunch of other agents that we use: anti-inflammatories, antispasmodics, smooth muscle relaxants, analgesics, things like codeine, tramadol, strong opioids, morphine, oxycodone, etc., etc. And we use a principle called multimodal analgesia. So when you're confronted with a patient with pain, generally a single medication is usually not that helpful, but using small amounts of different analgesic medications and other medications in combination, otherwise known as this multimodal analgesia, can be really quite effective. That's just to say, this is the WHO's pain relief ladder. At the bottom, You'll be giving patients things like paracetamol, anti-inflammatories. You step up, you might add in weak opioids, as we said, codeine, tramadol, tapentadol, etc. And then at the top, you would use opioids. So this is the morphine, oxycodone, etc. Now it says at the top, freedom from cancer pain, because this is a cancer pain ladder, but we've actually stolen it and we use it for the same purposes, but for non-cancer pain. There are an awful lot of different psychological treatments. This tends to be the realm of clinical pain psychologists. That's psychologists with a specialist interest in patients with pain. So this can include counseling, CBT, EMDR, RTMS treatments, and also group therapy, which we'll talk about later. There are minimally invasive procedures. So essentially, this is things like injection of local anesthetics, of steroid preparations, of Botox. And this tends to be done under X-ray or ultrasound guidance. We also use technology called radiofrequency. And there's two types of radiofrequency. There's a destructive radiofrequency denervation and a non-destructive radiofrequency, pulse radiofrequency, which we use to try and treat nerves. Botox, we've mentioned, we use that quite extensively these days. And then at the more advanced end of things, we use nerve stimulation. So this is referred to as spinal cord stimulation or dorsal root ganglion stimulation. And essentially, these are implantable electrodes which are put next to the spine, and as you can see in the diagram, they're tunneled under the skin and they go to a little battery pack which has a small CPU in it, and patients will often have a handheld remote control device in order to alter the settings of their spinal cord stimulator. And essentially, I mean, it's clearly more complex than this, but essentially it's a very expensive implantable TENS machine is a simple way of looking at it. Now, physical treatments, I've deliberately put this last, and the reason I've done that is because, in my opinion, all the treatments that we offer patients to improve their pain, whether it's drugs, injections, surgery, spinal cord stimulation, whatever, all of those treatment modalities are essentially there to try and reduce pain as much as possible. But the next step really is rehabilitation, physical and to a certain extent psychological rehabilitation, all of which is done by the pain physiotherapists. So physical rehabilitation therapy includes graded exercise programs, strength, flexibility training, cross training, and functional improvement, basically improving a claimant physically as much as possible, making them less dependent, reducing their care requirements, reducing their future care requirements, and hopefully, ultimately, the aim is to return claimants to the workforce if they're out of the workforce, to get them back into employment. That's a very important function of pain medicine. When I said earlier, physical and psychological, most pain physiotherapists actually do a lot of sort of under the radar psychology with the patients to try and get them to confront their pain, get them motivated, interested, getting them to try and do the exercises themselves and make them more self-reliant, which then improves their outcome. So then we look at future employment. Obviously, the starting point for this has to be pre-index events employment. What was the claimant doing? Were they full-time, part-time, not working, in education, retired, etc., etc.? As a generality, employment is seen to be therapeutic in pain medicine and medicine, and it's to be encouraged. Why? It has psychological benefits, physical benefits, social benefits, and financial benefits. So it is very, very important not to just improve patients' pain and get them moving a bit. It's important to improve patients' pain, improve them physically, rehabilitate them physically and psychologically, with an ultimate aim of returning them or getting them into the workplace. Future care requirements, same thing. We look at the pre-index events care requirements. And again, as we've talked about, the importance of treatment is really to make patients, is to minimize their care requirements, to increase their independence. They may require some assistance with heavy domestic tasks, obviously, depending on the pain and dysfunction that they have. And at the bottom, I've put when and if you have claimants who do have more complex care needs, then really we're looking toward an expert witness in care to give us information about that.